Good morning, everyone. Sorry about the delay. Today's speaker is Dr. Francois Steyn, qualified in 2007 as a medical doctor. His work experience has spread over four provinces in South Africa and Ireland, and his main field of interest is anesthesia and critical care. And he's going to be talking to us today about vasopressors and inotropies.
Good morning, everyone. So, Taban asked me to talk about this after.
Can you increase your volume?
No, it must be hard.
This is my maximum.
Okay.
Otherwise, I'll talk louder. So, thanks, Taban, for inviting me to talk about this. I think we all use these on a regular.
Accessibility shortcuts, 19 items, voice guide, off.
Some of the finer details slip our minds, or there's some confusion sometimes going on about certain things. So if you have to go look at the difference between vasopressors and inotropes, vasopressors leads to vasoconstriction and increased mean arterial pressure by means of that. They differ from inotropes, which increase cardiac contractility, although many of these drugs has both vasopressor and inotropic effects. It's been used since the 1940s in medicine, but there's very few controlled clinical trials being done to compare the actual outcomes improved by different ones. So if you go look at the receptors from the physiology point, is the alpha-1. So all of you can remember the vasoconstriction, alpha-2, beta-1, and beta-2. So we use it in order to reverse shock. So shock is diagnosed as a life-threatening condition of circulatory failure, which is defined as cellular tissue hypoxia due to inadequate tissue delivery that is unable to meet cellular metabolic needs and oxygen consumption and requirements. It can initially be reversible, but it can rapidly become irreversible, leading to multi-organ failure and death. So the types of shock that we differentiate into is septic shock, cardiogenic shock, hypovolemic shock, obstructive shock, such as pulmonary embolus or pulmonary hypertension, neurogenic shock or anaphylactic shock. So if you go look at what surviving sepsis guideline says, for septic shock, the first line of treatment should be noradrenaline. Cardiogenic shock is dobutamine or dopamine. Hypovolemic shock, you want to correct the volume and you can initially add noradrenaline to up your blood pressure to where you want it. And then anaphylactic shock is where adrenaline is still being used. So if you look at the separate agents, noradrenaline increase both systolic and diastolic blood pressure. It, however, diverts blood flow from the skin, kidneys, and bowel to the brain and heart. It should be used by central line only. To mix it, you can put 6 milligrams in 100 ml saline or 5% dextrose water and run it at 0.05 to 0.3 microgram per kilogram. In a 70 kilogram patient, this will be 3 to 20 mils per hour. You can't bolus this, and if it extravasates with the peripheral line, you can infiltrate the tissue with phenolamine to decrease the chances of tissue necrosis. Dobutamine is a synthetic isoprenaline derivative. It increases cardiac contractility and the heart rate. It modestly decrease systemic vascular resistance. So you mix it also in saline with 5% dextrose. You can give it via peripheral line, and the dose range is 0.5 to 40 mics per kilogram per minute. Dopamine is a natural occurring catecholamine. It's both positive inotropic and conotropic. It has the ability to increase renal blood flow via its actions on dopamine receptors and to increase urine out. It is used to increase urine output. It is a positive inotropic agent in low cardiac output state, impeding renal failure to improve renal perfusion and urine output, although there's no good scientific evidence that low-dose dopamine can prevent or reverse acute renal failure. The dose range is 1 to 20 mics per kilogram, and you also mix it in saline or 5% dextrose, and this you can only give via CVP. Adrenaline got both alpha and beta adrenergic receptors, which is dose dependent. At doses of less than 2 mics per minute, it's 1 to 2, beta 1 and 2. Between 2 and 20, it's alpha and beta. And at above 10 mics, it's predominantly alpha. And the dose range is I wrote down here. And this is one of the few inotropes where you can bolus if needed. Then phenylephrine is a synthetic alpha receptor antagonist. It's similar to noradrenaline, not more potent. It's quick to use. It's been used a lot in theater. You can also use it in casualty as a first line, as you can give it via peripheral line or a CVP. So the dose I wrote down there. And you can also bolus this at 50 to 100 micrograms boluses. It's contraindicated in severe hypertension and ventricular tachycardia. Using caution of patients with hyperthyroidism, bradycardia, or partial heart block, or ischemic heart disease. One that I don't think we use it that's not being used a lot is vasopressin. So that causes vasoconstriction via the V1 receptor. It also causes increase in volume by antidiuresis by acting on the V2 receptor in the distal tubuli of the kidney. It's been used for treatment of vasodilatory shock associated with severe sepsis unresponsive to noradrenaline. Also for vasodilatory shock post-cardiac bypass, unresponsive to noradrenaline infusion. You can also use it for uncontrolled bleeding of esophageal varices. And it's an alternative vasopressor to shock-resistant ventricular fibrillation. And you mix 20 international units with 40 ml 5% dextrose, and you run it at 10 to 12 mils an hour. So if we go back at the physiology, tissue perfusion is determined by cardiac output and systemic vascular resistance. So blood pressure is cardiac output times systemic vascular resistance. Cardiac output is heart rate times stroke volume. Stroke volume is dependent on preload, myocardial contractility, and afterload. And systemic vascular resistance is determined by vessel length, blood viscosity, and vessel diameter. How do we approach it? We do a clinical examination, look at perfusion peripherally. Is there mottled skin? Is there what clinical signs of shock you can find? Then initially you do a fluid challenge in a non-cardiac patient, 2,000 milliliters of warm crystalloids or 30 mils per kilogram. Do point of care sonar to see does your IVC collapse on inspiration, or how is your contractility of your heart? Then peripheral vasoconstrictors such as phenylephrine to correct the mean arterial pressure. Even though they say you shouldn't use noradrenaline peripherally, some people still do it. but you should have it in a good flowing free line. And yeah, just be aware of the risk for if it extravasate into the tissue. And then you monitor your endpoint, tissue perfusion, renal output, all of that. The question is always, how do we quantify that? So there's different ways of doing cardiac output monitoring. Invasive is a pulmonary artery catheter or a Swan's-Gunther catheter. Or if you have the ability, you can also do transesophageal echo and look at your cardiac output. You can calculate a lot of things from that. Less invasive, also from Edward Life Sciences, the Hemisphere Advanced Monitoring, which use a combination between your CVP, your arterial line, and a few other inputs to generate for you a cardiac output, peripheral resistance, cardiac index, all of that. In the Acumen IQ cuff, which is a cuff that goes around the wrist and the finger, and a saturation probe and all of that. And then you have the Foresight tissue oximeter, which you put on peripheral tissue, and then you can quantify the oxygen content in that. So I don't know which of you recently put in a pulmonary artery catheter. It did decline in use though, but you can get a lot of different values from that. Your central venous pressure, your mean pulmonary artery pressure, your cardiac output, your cardiac index, your stroke volume, index. The one that we monitor a lot is the systemic vascular resistance. And then, yeah. So there's a Swan catheter with all its different ports. You are limited by, you have to put it via the internal jugular artery, internal jugular vein, or the subclavian vein with the sheath that you introduce it with. So the controversies, one of the first ones I want to talk about is renal dose dopamine. So a lot of people quote the 3 micrograms per kilogram to protect the renal dose. This has been shown in normal volunteers to increase blood flow at 1 to 3 mics per kilo per minute. And then in animal studies, it suggested that low-dose dopamine in the setting of vasopressor-dependent sepsis can help preserve kidney blood flow. It's less proven in human. There's no data to support the routine use of low-dose dopamine to prevent or treat acute renal failure or mesenteric ischemia. The most effective means, according to UpToDate, to protect the kidney appears to maintain the mean arterial pressure over 60 while avoiding excessive vasoconstriction, not exceeding 1,300 dynes per second per square centimeter. This is why it's very important to quantify your cardiac output and systemic vascular resistance so that you can stay below this level. Then the other controversies is the optimal dose. Noradrenaline, if you see on my earlier slide, I said up to 30 micrograms per minute, typically used in refractory, is typically used, but you can use up to 100 mics. And in refractory shock and salvage therapy in combination with a second vasopressor, there's no established maximum dose, although there's no survival benefit of higher doses than this been proven. Then the other approach is to improve your cardiac output to supranormal, so more than 4.5 liters per minute per square meter, with the idea to improve your tissue perfusion and by means of that improve outcome. However, it resulted in no improvement or worsened morbidity or mortality. So yeah, and here's my references. I used UpToDate, and then Prof. Opie from UCT's Drugs for the Heart, Westmed Anesthesia, And then South African book by Milner and Wells, Applied Pharmacology and Anaesthesia and Critical Care. Can you hear me?
Yes.
So I want to go back to the controversies. The one that some people confuse, I think it's just because the names are so close, is the dobutamine versus dopamine. And I searched high and low, and dobutamine is there's no dopamine gets noted, but there's no reference to dobutamine and increasing renal outcomes or dialysis-free days or anything like that.
We have IV dopamine in South Africa.
Dobutrix only. Yeah.
We don't have dopamine.
Thank you so much, Francois. Nice presentation. Thank you for taking time to really prepare. I think we always say that the preparedness is it's not easy to prepare for presentation and our busy schedule. We appreciate it. Yes, I think you have mentioned quite a few controversy, but I always say that the most important thing is always to go back to your physiology and look what is actually the mechanism of action. So in critical care, probably is much more different from casualty, emergency ED. The issues about actually when you use of, we all know very well that most literature, in case of septic shock, the first line of anatrops is your noradrenaline. Is the first one. There's a lot of overwhelming evidence again about that, and obviously that goes to survival services guidelines, and obviously once your patient is properly resuscitated and you start on the Dobutrix on the noradrenaline, and then you struggle. Now, the question is that now when you go, my understanding that if you're going to map above 50 or your Dobutrix more than 50 mics already, means you're in trouble in context of the septic shock. And that's most of the studies suggest that you add the second anatrops. Now, the second anatrop to add in top of the noradrenaline depends on what's the underlying condition of the patient. Is it septic shock because of the peripheral sepsis, or is it because of a liver shock? So in our setting, we always have used adrenaline as a second line anatrops. And the most study will tell you, don't wait until you're on max of the noradrenaline. You have to give it earlier. So in this case, in our critical ICU, we will add adrenaline immediately, probably when we think that we can't get the MEP that we want, and the patient already getting optimal therapy instead of the steroid, getting dialysis, and ventilation, everything's well set. Lactate is still a problem. So with that adrenaline, but when you add the second anatrops, it's always very important to give a low dose of Dobutrix, which is about 2 to 5 mic max, not more than that. It's just to kind of antagonize, so that antagonize the action of the adrenaline and noradrenaline. And that's really studies that have been done. But what I would say that the problem that, again, I think you must just remember in life that whenever we download from the literature, it's what has been done in the past. So different centers will practice medicine differently, and they will obviously use a different kind of protocol to kind of address the underlying problem. Because at the end of the day, so in our ICU, we have a very great results with double anatrops. Most of them, in 24 hours, those patients actually kind of actually reverse their sepsis, because the problem the anatrops are there just to allow you to buy time until such time that your patient actually is fit enough, means antibiotic works, and then you can reverse the underlying condition. And sometimes with the family, if the family has not say DNR, you don't kind of withdraw. But obviously, I think in our setting, I think you are very right in certain things that in terms of the vasopressin, my experience that most patients go to vasopressin, the outcome is very poor. I never done very well with vasopressin at all. So we don't use vasopressin as much. But I know in catastrophic ICU, probably they use it much more than in medical ICU. So in ours, it's really the first line is noradrenaline. And if you don't get optimal MEP, and then you add adrenaline with low dose Dobutrix, and our results will be quite very excellent on that. Yes. So my question for you is like on the ED, because you have mentioned that actually based on survival guideline, you have to give 2 liters of fluid, and then after 30 mils per hour. Does that apply to everyone, or a particular selected group of patients?
No, if you look at that is a general rule from surviving sepsis guideline, but that is for the septic patient and the non-cardiac patient, because if you give a cardiac patient that volume, so it's either 30 mils per kilo as your bolus, or the 2,000 milliliters of crystalloid.
Yeah, so I think the most important question, the most important answer there is say that fluid is very great, but you always clinical may examine your patient, and your point of care ultrasound for cardiac is very, very important. So in terms of the monitors, the Swan gauge pulmonary catheter, that has got for a long time ago. So actually the only monitor that is very, very useful in critical care is the ED 1000. That's the only thing. The rest, the outcome is not great at all. Vigileo is out. All of them does not help you at all. Even IVC size, against operator dependent. So most of the time you have to go for clinical assessment. You have to use multiple tools of test from the collapse IVC, and also straight leg rising tests, capillary filling. You use them all together for you to get into see actually how much fluid you give. But most of the time, it's really you give the fluid until if you're elected to respond, awesome. If it doesn't respond, that means the patient probably now got septic shock based on survival sepsis guideline. Now, you got a question?
Yeah, no, I just want to find out. So you're talking about the surviving sepsis guideline. So actually, the new ones that came out in March of this year. That's the new surviving sepsis guideline. So. And this is especially for you guys because you are dealing with these patients first in EC. And what it says is you start with fluids. You don't wait for a fluid bolus. You start noradrenaline immediately. And you can give it via a peripheral line. So you don't have to put up a CPP line. So, and then once you go above 0.4, then you are at the second agent, and the second agent to them is now vasopressin. They recommend vasopressin, and that's the second agent to use. Then you also start cortisone, so hydrocortisone, and that is very important because by the time the patient gets to ICU, it's 3-4 hours down the line. And the important thing is not to just give the medication, but to then observe the patients as well. So you have to continue to monitor the lactate. You have to do capillary refill times. You have to look at the level of consciousness of the patient. You have to look at urine output. All those things need to be monitored.
Maybe your antibiotic.
Yes, and antibiotics obviously immediately as well. The other thing that they also said is to give prolonged infusions of antibiotics, and that's why the PIP dose. Now you give us bolus dose, and we continue with infusions. So that's yeah. And in your reading, what is the role of methylene blue?
Sorry, I didn't read enough about that to comment on it.
Okay.
Yeah, I think on that it's really hit the nail in the top, because the issue that I think survival sepsis guideline is very important. And I think, of course, there's a fear that you can't put peripheral noradrenaline, but we have done that for the last few years, actually, because you have to start something immediately, whatever you have to start while you get your lines. Because
But you can't casually put, because it takes time to prepare the line, to insert the line.
But also, if someone's
you need to be doing
But if someone's hypotensive, you will struggle to get the line in, to get a CPP in. So you can't have to start immediately. So that I think time for tissue is very important, that you have to act as immediately as possible in case of department. But again, it's not a substitute that you cannot now put the line. Okay. You still need to try to put the line after your BP is up. I think that's for me the most important.
Yeah, I think also, so with neurology, the stroke protocols is to try and get the anticoagulation in as quickly as possible. The same with heart attacks. Everything is trying to decrease the time. But I think people still forget about sepsis and septic shock. So that's still one of the biggest mortalities. And the sooner you start these patients, and it's the same. So once the patient comes in, the clock starts ticking. You have to give fluids, you have to give inotropes, you have to give cortisone, antibiotics, you have to look for a cause, blood cultures, and we can do a talk about the new surviving sepsis guidelines.
I think
We'll do that because they all those things that that you talked about, the monitoring. There's very important things about MAP. So what should your MAP be? Now, if you have a MAP of 65, you're happy about the MAP. But now for a patient who is hypertensive, a MAP of 65 is not going to be enough. All right, so they need a higher MAP. So you need to look at different targets for different populations. And I think that's where a lot of the issues comes in. So, but the important is everything is clinical. So trying to put on all these lines and stuff is, I don't think, CVP.
No, that's a benefit.
Yeah.
Increase of sepsis.
Yeah, and they also talk about values of your oxygen and the PO2 in your CVP. So you need to monitor the difference between your arterial and your venous oxygen delivery. So it becomes very tricky, but very interesting with all those things.
I think it's getting exciting. Content is reading critical care. Well done.
The other question, or the other thing that is interesting and a bit controversial as well, is what is your feeling about giving beta blockers in patients with septic shock and a tachycardia?
That is going to help him.
In my mind, it's a bit of a double-edged sword because you're potentially blocking the effect of your inotropes, but on the other hand, you do want to get the pulse rate down a bit. For the
So there's actually a lot of places that actually use beta blockers. So once the patient is fully resuscitated, so they full of fluids, but now they're running a tachycardia, a sinus tachycardia. You can't find another cause. You actually can give them IV beta blockers, and there's very new ones coming on the market that very short acting that actually prove to improve survival.
To, I think, increase your diastolic filling time in order to improve your cardiac output.
But please don't give. But once again, that is after 2-3 days in ICU once the patient is stable. But I think the most important thing for the EC people is start noradrenaline immediately. So don't wait. Give IV fluids immediately. You can start bolusing, and then the antibiotics, steroids, and then monitoring. Very important.
And don't hold back to start the second the anotropes if you struggle. If the BP doesn't come up, you go to 40, maybe you need to outside. I think in our setting, we use adrenaline really, because I think as a person, most time we did it, the outcome was not great. But again, I don't know, I can try and then see.
Yeah. As I said, so there is, on the surviving sepsis guidelines, it is the second one to use is vasopressin. And then you can add a third one. So there's also angiotensin antagonists or agonists that they start using. It's very expensive. We don't have it in South Africa. We probably won't get it, but that actually they use third agents for that as well. But I think if we must stick to basics and what we have available. So the rest is all up for. And once again, you must look for a cause. But we're talking about sepsis. That's probably what we see most of the times.
So yeah, interesting. They said in terms of shock being admitted to ICU, 62% is septic
Sepsis.
shock. 16% is cardiogenic shock. Another 16% is hypovolemic shock, and 4% is distributive shock. So either anaphylactoid or neurogenic shock. So septic shock is by far the biggest one that you would see in ICU.
Yeah, I think midstream is most septic shock actually is the biggest. That's why for me adrenaline work better.
Yeah,
If
that's more than
more better. But if it's I always would use vasopressin if there's underlying liver ischemia. That's for me. I think that's when I come to use it, and that. But I think on that say it clearly here. The most important thing, don't delay, is start your things on time and get the patient to ICU.
I think the other point that you make on now that is very important is not underestimate how severe the situation is, because often you're seeing a hypertensive patient, a patient who's normally on antihypertensive. So now the blood pressure is 100/60, and maybe you think it's not that severe.
For someone,
You've got time, but actually in reality, in that patient, you've got very little time.
So you
It's shock
actually,
already.
Yeah.
This is not.
as I said, so a map of 65 is probably not enough for an 80-year-old patient on antihypertensives that comes in. You have to aim for a higher map. And then, the other question that I asked for methylene blue. So you can actually use methylene blue. What I've read, I've never used it. I use it in cardiothoracic surgery quite often. But apparently, if you have resistant or refractory septic shock, you can give a dose of methylene blue. It releases the nitric oxide, which helps with perfusion. So
I think in the past they come with that. They also used to say actually you can give the patient nitrogen infusion together when someone's septic shock to cause vasodilatation. So there are quite a lot of things that coming. That's why we always talk about antigen therapy, something that you could add on to improve your survival. And the thing is that, you know what, one of the things which I really wanted to have a very good take-home message was that your patient is never dead until he's dead. And while your patient's alive, you have to try whatever you can, don't rely just on the studies, because those studies are outdated. So the most important that you must do personalized therapy on your patients. Means you might have to try new tricks to try to get your patient out of the wound. And if you look at our setting, I think our mortality is not actually that bad. I think compared to the rest of the hospital, we have really very good mortality rate. And also, of course, most of the patients with septic shock, we manage to pull them out within 24 to 42 hours. 24 to 42 hours. Because if you're septic shock, after 72 hours, it's not reversing, then there's a problem. So within 24 hours, you should already start winning your inotropes. If you start everything at the right, if you understand, I think in our setting, we have biofire, which most of the time really identify the source of infection and guide us. We do CRE immediately, and that means we can adjust our antimicrobial according to the sensitivity empirically, quite the right one and right dosage. So for me, the issue is that it's not really about the septic shock. It's about actually what causes sepsis. What can you use for urosepsis? What can you use for pneumonia? What can you use for intravenous sepsis? Because if you get the right antimicrobial, most of the time within 24 hours, you can reverse the sepsis quickly. Otherwise, any other questions, Danny? Any comment, wisdom?
No, the only thing is, this is obviously for medical patients, but again, the trauma patients, they're also moving away from large volumes of fluids, these giving fluids. But they say that you give your first dose, even up to 500 ml, start blood products as quickly as possible.
Yes.
And the massive transfusion protocol as quickly as possible. And the thing with burns is that if you get a burns patient, you start with 500 moles immediately, and for children.
The fluid. I think our my next discussion I'll talk about fluid in fluid management. Then maybe you can chat about which fluid is the best actually for us to use in our setting, and then maybe form a guideline.
But as you said, you must find the underlying cause for
let him go. Yeah, I think it's important. Are you all right? Otherwise, any other question from your side? Okay, we close online. Any question, comment?
Thank you so much for the opportunity. My apologies again. I didn't know I had to be there in person. Otherwise, I definitely would have been there.
Well, we still expect you to come in person, Francois. You are not off the hook still. So we'll give you another day, then maybe 6 months from now.
Okay. Thank you so much.
All right.
Okay.
Bye.
Thank you very much. Bye-bye.